Thank you so much, Amanda, for that introduction. And I have a pleasure of knowing you as well. And working together with you on some really exciting projects postpartum. So I've got 15 minutes. So I'll try and get through all my slides. It's my pleasure to be able to talk to you about these new novel biomarkers that we discovered and patented. For those of you who are not too familiar, preeclampsia is a cardiovascular disorder of pregnancy that affects 5 to 8% of women and 1 in 12 women in Australia, in fact. Pre-existing conditions such as diabetes can actually increase the incidence of preeclampsia up to 4-fold. Preeclampsia does not have a cure and often leads to premature birth because the only actually cure is the delivery of the placenta and the baby. And it can be very costly, lead to hospitalization and complications. Post-pregnancy, preeclampsia is associated with increased risk of cardiovascular disease and metabolic disease as well, where 2 out of 3 women actually die prematurely from cardiovascular disease. And having said all of that, personal approaches to monitoring and treatment actually do not exist. And this is the end area of unmet clinical need that we are trying to address. So there are different phenotypes of preeclampsia that have so far been established. So there is an early onset preeclampsia that occurs before 34 weeks of gestation. And it's associated with more severe features, but it only captures about 15% of the overall preeclampsia cases, whereas late onset preeclampsia that occurs after 34 weeks of gestation is sort of potentially a milder version, but it's still associated with the similar morbidity and mortality as well. However, it captures about 80 to 90% of the cases. Most of research has been done actually in early onset preeclampsia. In early onset preeclampsia, but there is a lot more to be done in the late onset preeclampsia. So in terms of the pathogenesis of preeclampsia, we're still trying to understand what actually leads to this condition, but early in pregnancy, the scene is set. So what happens is that preeclampsia is not developed properly, does not grow properly because of the abnormal trophoblast invasion. Then there is anti-angiogenic response, inflammatory response as well, that can lead to placental hypoxia, ischemia, and fetal growth restriction, amongst other cardiovascular features. So we then started to explore the role of this novel anti-angiogenic protein FKBPL in preeclampsia. The background work to this research has been based on the role of FKBPL in cancer. So during my PhD, I was working on this protein where we actually developed FKBPL-based therapeutic peptide that was able to cut off the blood supply from the tumors. And we established that it had anti-angiogenic role. So the peptide has been developed now and it has completed phase 1 clinical trial and has received orphan drug designation by the FDA for ovarian cancer treatment. But what intrigued me and how I've taken this work into preeclampsia was that actually when we tried to develop FKBPL transgenic mice that had knockdown of FKBPL, we were actually unable to obtain and to establish knockout colonies because they were embryonically lethal. So mice which had both alleles of FKBPL deleted were embryonically lethal at about E8.5. So that obviously then made us realize that it has a critical role in developmental angiogenesis, but also physiological and pathological angiogenesis. It also regulates some of the steroid hormone signaling as well, which is important in pregnancy and in preeclampsia. So what do we know about FKBPL? It's an intracellular protein that is part of immunophilin family of proteins. It's secreted mostly by fibroblasts and endothelial cells, but it is very highly expressed in placenta. Actually, placenta is an organ that expresses it the most out of all the other organs in the body. So that obviously is another suggestion that it could have a very important role in it. It's anti-angiogenic, anti-migratory, and it works via the CD44 pathway where it binds to CD44. And CD44 has many, many roles in cell function, but also angiogenesis and stem cell signaling as well. So when we measured CD44 and FKBPL plasma levels in patients from the SCOPE cohort from University of Cork in Ireland, we actually realized that CD44 and FKBPL ratio were an independent risk factor for preeclampsia. These samples were actually collected at 20 weeks of gestation. So these patients were asymptomatic but they proceeded to develop preeclampsia later on in pregnancy. So in terms of its predictive potential, the ratio, which is based on this novel pathway, completely independent of S-FLT-PLGF or VEGF, in fact, could be used for prediction of preeclampsia, and it was independent of all the clinical characteristics. Then what we wanted to do is see if the levels were different or the expression was different in established preeclampsia. So this is a separate group of patients with diagnosed preeclampsia, which were patients that were symptomatic. So when we actually measured FKEPL in these patients, we could see that actually FKEPL was increased in women who had preeclampsia, who were diagnosed with preeclampsia, whereas CD44 was actually reduced. And this is actually opposite to what we see early on in pregnancy. So there is that interesting longitudinal change, which is quite complicated as well to understand. But overall, the CD44 FKPL ratio in these women with established preeclampsia was overall reduced. And what that meant to us is that before preeclampsia, potentially, there is that compensatory angiogenesis that body is trying to push FKPL down and increase CD44 to stimulate angiogenesis and the growth of the placenta, because essentially something is going wrong. But then once preeclampsia is established, then it's a well-known anti-angiogenic state. And in that case, CD44 goes down and FKPL goes up and overall ratio goes down, because CD44 is highly secreted in the plasma, whereas FKPL is lowly secreted in the plasma as well. So then we confirmed this data in a separate independent cohort of women with early onset preeclampsia. So these are women who develop and who are diagnosed with preeclampsia before 34 weeks of gestation. And we found exactly the same results, which was very encouraging. What was interesting is that plasma FKPL was negatively correlated with infant birth weight. So the higher the level of FKPL in the blood, the lower the birth weight, which kind of makes sense, given that a lot of women who have preeclampsia deliver sort of small for gestational age babies. And then the plasma ratio, in fact, was negatively correlated with the blood pressure, which meant that when the ratio was low, blood pressure was high, which is, again, typical of preeclampsia. The diagnostic potential of the biomarkers was satisfactory, with a sensitivity of 73% and specificity of 93%. And this is using ELISA, commercially available ELISA kits. So what does actually FKPL do within the placenta, given the placenta is the root cause of preeclampsia? What we actually did next was measure the expression of FKPL within the placenta, because we actually didn't even know what type of cells express FKPL within the placenta. So from these immunofluorescent imaging, you can see that FKPL is actually expressed in the trophoblasts, which are the cells lining these little sections of the placenta, or syncytials. But it's also expressed within the endothelial cells, which are the middle, the cells in the middle as well. It's hard to actually move this around, but anyway, you see, hopefully you understand what I mean. And then when we measured the expression at the mRNA level, we've seen exactly the same trend, where CD44 was increased and CD44 was decreased and FKPL was increased, because these are obviously placentae from women who had preeclampsia and then delivered as a result of that. Again, in an independent cohort of placental sections, we've confirmed the same, that FKPL was increased in placenta from women who developed preeclampsia compared to the control and normal intensive pregnancies. So more recently, we developed these multicellular placenta on a chip model to actually understand how FKPL is regulated between the trophoblast cells and endothelial cells, which are the two critical cell types of placenta. Because what trophoblasts do, they go into the maternal endometrium and remodel uterine arteries to actually allow unlimited supply of oxygen and nutrients to the baby. And therefore, that interaction between trophoblast cells and endothelial cells is really critical. So what we've actually seen in the first sort of model, where we've only had trophoblast cells on the outside, in the outside channels here, and collagen as an extracellular matrix in the middle, where trophoblasts actually invade through the side channels into the middle. We've seen that FQEPL after 24 hours of treatment with TNF alpha, which is an inflammatory stimuli highly expressed in preeclampsia, actually reduced FQEPL expression, and then after 72 hours, it increased FQEPL expression. So there is that longitudinal change that we see in patients pre in asymptomatic women and then post in symptomatic women with preeclampsia. Interestingly enough, when we looked at the HUVEC, which are the endothelial cells, alone without trophoblast cells, we've seen kind of slightly different picture, where there is no change at 24 hours of TNF alpha treatment and reduction in FQEPL at 72 hours TNF treatment, which could be as a result, again, of compensatory angiogenesis, because TNF alpha at that point as well, I don't have time to show you the data, but it was also reducing the angiogenesis. So it kind of fits with the reduction in FQEPL. Finally, when we combined the two cell types together, again, the story was also different, whereby we had trophoblast cells on the side channels and then HUVEC in the middle, where trophoblasts actually invaded and remodeled those HUVEC networks that formed in the middle channel of this placental chip model. And then we measured trophoblast expression of FQEPL. We've seen increase at 24 hours and then decrease at 72 hours. And that was also similar in the endothelial cells that were interacting with trophoblast cells at that point. So complex picture, but what it does prove to us is that there is that differential change and expression of FQEPL with different exposure to inflammatory stimuli, which we are looking to elucidate what exactly this means still in this model and in human placenta. So to summarize this part of the talk, as a prediction, what we see is that at 20 weeks of gestation in asymptomatic women who do not have preeclampsia at that point, we see increase in the ratio, which is CD44 FQEPL. And that is reflective of compensatory angiogenesis, where body is trying to push the angiogenesis, sensing that placenta is not growing properly or developing properly. Whereas in the third trimester, when actually preeclampsia is diagnosed and women develop symptoms, the ratio goes down, and that's reflective of restricted angiogenesis. So the way that we see this, we are sort of working towards commercialization, and we would like to see this in the clinic eventually. But what we are proposing is that at 20 weeks, when women actually come in for the abnormality test, and then they would have various tests amongst measuring FQEPL and CD44. And if the ratio is high, then they would need closer monitoring, more intense monitoring of blood pressure, proteinuria, another FQEPL test as well later on to catch that change, the longitudinal change from high to low. And potentially digital health could have a role here, given that there is no treatment for preeclampsia, but exercise has shown to actually reduce the risk of preeclampsia, and closer monitoring has also shown to lead to timely diagnosis. If the ratio is normal, then the usual care continues. So because most of the women who develop preeclampsia and die for preeclampsia actually that normally happens in remote areas or in developing countries. What we wanted to do next is develop a point of care test for this condition using these two biomarkers to allow those immediate clinical decisions and timely management, but also to allow potentially women in the remote areas and developing countries to have better care and better monitoring as well. So this is a platform that was developed by my colleague, Professor Daeon Jing at University of Technology, Sydney. It's a highly sensitive point of care platform that is not available on the market yet, but they're going to hopefully getting there. It's based on the up conversion nanoparticle that is fluorescent and highly doped. So when you actually conjugate your antibodies with this upconversion nanoparticle, you can get a really strong signal, and it should increase sensitivity and detection of the lowly secreted proteins, in particular, that FQEPL is one of them. And then what we did, we developed the lateral flow assay, where we've have sort of a sample pad. It's just like a pregnancy test, like a COVID test for home as well, where we've conjugated our antibodies with the upconversion nanoparticles, and then we tested using antigens, but also plasma samples from the patients to see whether this actually can measure FQEPL and CD44 in real patient samples, but also whether we gain the same results. Again, it worked very nicely where we could see those dependent response in terms of the FQPL detection and CD44 detection. So we were happy with that to proceed further. And there was no crosstalk between CD44 and FQPL, which meant that, again, the combination of these two antibodies were suitable for this lateral flow assay in the point of care settings. So then, just to finalize, then we validated our point of care test using patient samples from the early onset preeclampsia. And in fact, we've seen exactly the same results. So this was our third validation of the biomarkers where FQPL is increased, CD44 is decreased, and the ratio is overall decreased. But what was really exciting is that this actually point of care assay was highly sensitive and improved sensitivity by 20%. Whereas specificity was at 100%. So it's really exciting to see that. And it could be incorporated into the digital health platform going forward for remote monitoring. That's it. So thank you to my team stars who have done this work. My PhD student, Sahar Gorbanpour.
Thanks very much, Lana. Now, yes, so I've got the roving mic for here. Do we have any questions in the room to start? And Isabella's going to take the online. Oh, yeah. He's got one. Excellent.
Yep. Now, I was just wondering how expensive the biomarkers would ultimately be, you know, once the tests, basically.
The good news about point of care assay is that they're cheap and cost effective. Of course, initially when you're in the development stage and when the manufacturing is limiting, that's going to be sort of a lot higher than later on. But the idea and the hope is that these point of care tests should cost a few dollars really down the track when this is all established in manufacturing and widely distributed. But initially it might be a little bit more expensive.
Katie.
Thank you. I think it's sort of a two-part question. So are there any other biomarkers for predicting preeclampsia, and how well does your biomarker sort of compare to just looking at blood pressure, for example?
Yes, great question. So there are two sort of biomarkers which are very well known for prediction and diagnosis of preeclampsia. They're called SFLT and PLGF. PLGF in particular has been in the clinic, and it's so they have similar sort of profile at about 20 weeks. You can start to see the changes which could potentially predict those that will develop the preeclampsia. Our biomarkers compare well with those biomarkers, but what is really nice about these biomarkers is that longitudinal change from sort of high levels to low levels, so you get that personalized sort of reflection from the same patient over the time period as well, so that you can catch it early, whereas the other biomarkers don't do that.
Nothing on mine. Yeah, so I might sort of follow through with that, because as you mentioned, although a lot of the effort has gone into preterm preeclampsia and preterm prediction, that is the minority of cases, and the bulk of disease is both here and in the developed world is the sort of near term. But do you have sort of how well your biomarker goes with that?
Yes, so absolutely. So our initial prediction cohort was mainly term preeclampsia or late onset preeclampsia, depending how you want to call it. The reason why we focused lately with our point of care assay on the early onset preeclampsia was because it was it's a proof of principle. So we thought if we can see the signal in early onset, which is a little bit more sort of severe disease, then we can progress then to the term disease as well. But certainly we believe, based on the data that we've collected so far, that it will be also useful for term disease.
Excellent. All right, any other final questions for Lana? Okay, super. Thank you so much.
Thank you.
You beat the clock even. Okay. So our second speaker is Dr. Emily Atkins. As you can see, the title of her talk is Hypertension and Health Economics. So Emily's a senior research fellow with the cardiovascular program at the George Institute for Global Health. Dr. Atkins is working on a number of studies investigating different methods to improve efficacy and use of blood pressure lowering therapy. And her recent focus has been on the health economics of blood pressure lowering medicines, including conducting cost-effective analysis of the QUARTET trial. She's interested in affordable and equitable improvements in cardiovascular medicines use globally, and also seasonal and climate effects on blood pressure. Thank you very much, Emily.
I just realised I should probably have dropped that last bit out because I'm not going to talk about it today. But I think it's kind of cool. Yeah. Okay, so let's see. First of all, I'd like to acknowledge that I live and work on the land of the Gadigal people of the Eora Nation. I pay respects to elders past, present and emerging, and extend that respect to Aboriginal and Torres Strait Islander people joining us today. Okay, second, trials require a lot of work from a lot of people, and I want to acknowledge the contribution of my colleagues and the trial participants in achieving the results that I'm presenting today. Thirdly, QUARTET was funded by the NHMRC. The quad pill pilot and my postdoc fellowship were funded by the Heart Foundation. Finally, acknowledging my family, my husband Michael and my son Felix. I'm grateful everything came together today to allow me to do this work and share it with you. So what am I going to talk about? I'll give a quick intro, go into the stats about hypertension, the numbers of people, prescriptions and appointments. Then I'll add up how much that costs. I'll move on to the QUARTET cost effectiveness analysis. And if I get time at the end, I'd like to pitch economic evaluation to you. Okay, so I went with a broad title because I wasn't sure what I was going to talk about. And this is the space that I'm working in. I have a couple of projects bubbling along and I'm keen to share them with you today. So yes, I'm sorry. Hypertension is probably the least exciting disease to be studied. It's so common. We all know someone with high blood pressure if we haven't experienced it ourselves. And it doesn't even make you feel ill. You don't know you have it until your doctor tells you. And if you have it, what do? You watch what you eat, exercise a bit more, pop some pills. And I followed the word hypertension with and health economics. I'm sorry about that, because if there's anything less exciting than hypertension, it's got to be economics. Please preemptively get out your phone and start scrolling Insta and Twitter, because I'm going to start talking about value for the health dollar. There's going to be some numbers and formulas in my talk. It's a requirement. PowerPoint just auto-completes it for you. If you put the words hypertension in there, it's like, oh, you need prevalence slides. And if you put economics in there, it's like, you've got to have formulas. So the numbers, 1 in 3 Australian adults, that's 6.5 million people, have high blood pressure. For a 2.1, yay, they're getting, they have blood pressure control. Their medicines work for them. But there's 4.4 million people who could have better care. Their current treatment isn't achieving their goal, or they're not receiving any medicines for their high blood pressure. And we know the global burden of disease studies demonstrated that high blood pressure is the leading risk factor for preventable deaths globally. So something about the way we're currently doing things isn't working for 2/3 of Australians with high blood pressure. So what's happening? We have heaps of low-cost blood pressure lowering drugs available on the PBS. A packet of blood pressure pills is a few dollars. It's not largely a problem with the price or availability of medicines here. There's a hurdle before that point. The thing I think is the problem is the way we're approaching diagnosing and treating high blood pressure is a bit old-fashioned. Many countries updated their diagnosis thresholds and their treatment algorithms following Sprint. And Australia said nah to that opportunity. So we get a high measure And then you start diet and exercise for 6 weeks. After that time, you go back to your GP. If your blood pressure is still high, then you start one drug and you go away and you come back in a few more weeks. And if you're getting side effects or it's not quite enough, you might get a second drug, you might get swapped onto a different drug. And then you come back after a few more weeks. So it's a slow, conservative approach. And these first 2 steps are low risk and they can benefit for some people. But for most people, it's not enough. And for most people, they're only getting that first 2 steps. Here in inner West Sydney, getting a GP appointment is easy. I can log into the app and book an after-hours appointment with my usual GP and go and see him within a couple of days. The regional city where I grew up, you would be waiting 4 to 6 weeks to just get that initial appointment. And it had to be in office hours. So you needed to be motivated and have the resources to get there and make that appointment happen. Follow-up appointments on something where you're feeling okay and you've already got a pill to take, it's not going to be a high priority, or it might not be a high priority unless you're really motivated and you've got those resources to make it happen. Okay, so back to numbers. I've been working on adding up the cost of treating hypertension in Australia. And this is a project with Professor Anthony Rogers, Professor Alter-Schutter, a pharmacist, Long Nguyen, and Dr. Sonali Ganantharan. We added up the dispensing on hypertension drugs in the PBS. And there's about 54 million dispensings. 35 million of these are subsidised by the PBS, so the rest are patients paying out of pocket. The fun thing about our system is we only give a month's supply at a time. So to maintain stable treatment for a lifelong condition, you have to go see your pharmacist every month. For GP visits, about 1.5% of GP visits in Australia list hypertension as the primary reason. That's from Medicine Insight data. 7.5% of GP admissions include an element of hypertension management. For costing purposes, I'm only counting that first 1.5% because it seems like the other GP appointments would have happened anyway. So adding up all those GP visits and all those medicines, we get a total spend between the government and people with hypertension of $1.3 billion last year. And where does that money go? Well, the GP visits are the orange segment. Can I get the mouse up on the screen? Here we are. The orange segment? Nope. Orange segment. And then the rest is the pills and the people who handle the pills. So the medicines cost is that blue bit. The wholesalers cost is that red bit. And then the green is the administration fees, which is per item, so per packet. And then the purple bit is the dispensing fees. And that is also per item, so per packet. And so you can see how monthly supply is driving the portions of this pie. Something to ponder on, wonder whether we're actually getting good value there. Let's move on to something more fun, the formula. Okay. So this is the only formula slide in the talk. I'm going to talk to you about cost effectiveness analysis. The result that we look at is the incremental cost effectiveness ratio. And this is the change in cost with the intervention over the change in effect or outcome. And it's expressed as a cost per consequence, like $50,000 per quality adjusted life year. We use cost effectiveness analysis when deciding on new medicines and other technologies to be reimbursed by the PBS and MBS. And this came about as a way to ensure that we're getting good value from our limited healthcare budget. It's a way to ensure everyone can receive a basic level of care through our public health system. And when we add up the cost, it's not just the cost of the intervention itself, it's the cost of the healthcare use that's driven by that intervention? Are there more GP visits? Are there less hospital admissions? Is there more physio time, less cardiologist time? These all contribute to the costs. The effects or consequences can be things like millimeters mercury of blood pressure reduction, cardiovascular events prevented. And these are the kinds of outcomes we're used to seeing in trials. But we convert these into like quality adjusted life here, so we can compare different types of interventions and also compare them against a threshold of what we've decided is cost effective. Okay. So the cost effectiveness analysis of QUARTET. I've been working on this with Alex Kai and Dr. Tom Lung. It's a work in progress. It's not yet published, so my slides are a bit minimalist. The QUARTET trial was led by Professor Clara Chow and Professor Anthony Rogers, and I had the great fortune of joining the team as a new postdoc in 2015. I got to learn a lot about blood pressure lowering trials in that process. The QUARTET trial compared initial quad pill, which was a single pill combining 4 drugs at quarter dose. It was angiotensin receptor blocker, a calcium channel blocker, diuretic, and a beta blocker. And we compared that to initial monotherapy with irbesartan, you can see here. And this was consistent with the current guidelines. We had a fantastic result. The blood pressure at 12 weeks was lower, had better blood pressure control. And that's the reference there. Go and click on my link and cite it. So I got to do the cost effectiveness analysis. There's 2 components to the economic evaluation. So I've done a within trial analysis, which is looking at the cost per millimeter mercury blood pressure reduction at 12 weeks. I collected up the health services, so I asked people about their GP visits, their nurse visits, their hospital visits, and also their medicine use within the trial. And I added it all up and divided by the delta. I also had this modeled model component as well, which took that blood pressure reduction and then extrapolated that out to cardiovascular events, or cardiovascular events prevented, and then QALYs. We used the Globo risk equation to estimate the risk of heart attack or stroke. We used age-specific norms for QALYs from South Australia, and we had to use UK data for our QALYs for cardiovascular events. If someone wants to do Australian ones, I'd love it, please do. We generated 1,000 sample patients from the baseline characteristics of the QUARTET participants, and we ran them through the model and then did that 1,000 times to generate our uncertainty estimates. Okay. So the within trial result was an incremental cost effectiveness ratio of $10 per millimeter mercury for quad pill versus monotherapy at 12 weeks. And our 95% uncertainty interval ranged from saving $18 up to a cost of $37. The quad pill arm had a little bit more health service use. Their medicines cost a little bit more, but they also had that better blood pressure reduction. Because the study visits were fixed, that health service use was driven by participants using non-trial services like their GP. And you can see the natural unit here, millimeters mercury blood pressure. It's not very easy to compare with different types of interventions. So this is why we use QALY in the model. Okay. So based on that blood pressure effect at 12 weeks, continuing, assuming adherence, we estimate there'd be a 3% reduction in cardiovascular events with the quad pill compared to usual care. Our base case showed a saving of $82 and a difference of 0.3 QALYs per person at 10 years. So, 82 up here. So our incremental cost effectiveness ratio is in this bottom right quadrant of the cost effectiveness plane. and we call that dominant. The intervention saves money and is more effective than the comparator. This ellipse, so the dotted line, shows our confidence around that estimate. 3/4 of that 1,000 replications fell below the line. So that shows the intervention's cost saving to the comparator. All our estimates are to the right of this dotted line, the diagonal, which shows 50,000 per QALY, which is used for determining if new pharmaceuticals are cost effective in Australia. And they're also all below that blue line, which is our reference threshold. Is that my time? Okay. So that blue line's a threshold for health technologies in Australia. So it seems to be where we're okay with spending things. If we lower the cost of the quad pill, it shifts that whole thing right down to the bottom. If we have a less effective outcome, so using the lower limit of the confidence interval, it bumps the result up into that top right quadrant, but it's still below both those lines. So to conclude, smiley face. It's looking like a no-brainer. It's less expensive and more effective at 10 years. And we see from the sensitivity analysis that if the effectiveness isn't quite as good as outside the trial situation, it's still cost effective. If we can make the pills cheaper, more savings. So maybe this is something that could be pursued as a product. And I'll stop there. Thank you. My contact details are...
Thanks so much, Emily. Questions?
Thanks, Emily. That was a great talk. I didn't quite catch what you said we needed the Australian data for. You said something around QALYs and you had to use UK
Oh, yes.
data.
So we don't have Australian data for our utilities post cardiovascular events in Australia. So basically how your quality of life decreases post-event. It's published for the UK, but we just haven't got that for Australia.
Nothing from online, or they're all silent online. Great, thank you.
Thanks. In relation to the cost of medication, so if all antihypertensive medicine is on PBS, so if you go to the doctor and you prescribe the medicine to go and buy it, do people not buy it because it's expensive? The cost, is the cost relevant on medication which is on PBS if you are prescribed the medication?
Look, for some people it is. If you've got lots of drugs that you need to buy, there's particularly for people who are on a pension, you have to spend a significant portion of your limited income on medicines before you hit the safety net threshold. I don't think for most of the people with hypertension that cost is the problem. I think there are other barriers.
What is the problem for these people?
I don't know, apathy. Yeah, adherence is a challenge. I mean, it's lifelong medication for something that you don't feel to reduce a risk of something that might happen. It gets a little abstract.
You don't feel sick with hypertension. You don't feel any.
You don't feel it, and if you're on pills and you get, you know, a little bit dizzy or something, and that's attributed to the pills, and you're like, well, why am I taking these? They make me feel worse.
So in terms of all this awareness, I mean, at the recent hypertension meeting in Kyoto, it transpired that the Canadians are making a huge progress. Maybe somebody can explain why, how come they're making a bigger progress than anybody else in this awareness and treatment and so on.
My idea is they update their guidelines as the evidence is updated. They issue new guidelines fairly regularly. So I think with that, there comes a lot more awareness on the clinician side of where the evidence is at. I think we're falling behind here. People are nodding, that's
Emily, it was quite striking the proportion, like the breakdown of the cost of medication, sort of about 3/4 of it really was the sort of dispensing kind of cost. But yeah, as you say, we've kind of got this insistence on sort of monthly repeats and things. Is there a way forward there?
Do you want to take on the guild?
Yeah, well, it was a really good demonstration of perverse incentives.
Yeah.
But okay,
Yeah.
that's really the bottom line. As in any strong safety arguments to be made for, why it needs to be a month.
Look,
I mean,
at the beginning, there is
Yeah.
a good reason to be reviewing. But for maintaining long-term therapy, if people know they take this drug and that works for them, does coming back every month really do anything apart from, okay.
On that happy note, well, thank you very much. A very interesting talk.